Bonjour, mon nom est Amélie Canal-Vallée.
Hello, my name is Emily Cananari. I'm a professor of sociology and technology in McGill, and I'm the chair of the research chair and policy in public health inequalities.
Moderate the opening session to this day that will allow us to take stock of lessons learned from COVID-19. The past 20 months have brought countless challenges and profound suffering for so many of us. And it is not over yet. And many are struggling to recover. Our thoughts go out to them. Let us hope that the suffering was not in vain and that through knowledge such as will be shared today, we might rise above the fault lines that COVID-19 exploited. Professor Mill's presentation today will shed light on these faults and provide insights where we need to. Research spans demography, empirical sociology, statistics, and I just lost my light, I'm sorry, genetics and medical sciences. She has brought scientific acumen in the service of the UK government's Science Advisory Group for Emergencies and Vaccine Science Coordination Group, and to the Royal Society's Science and Emergency Tasking COVID-19 Group. She is one of the European Commissioner's 8 expert advisors on the high-level group on post-COVID-19 economic and social challenges. So before I turn it over to Professor Mills for her presentation, I want to remind you to post your questions in the chat. I will moderate them and put them to the speaker at the end of the session. So Professor Mills, on to you, and thank you for joining us.
Thank you, and thank you very much for the kind introduction. I'm joining you from Oxford, but as some of you might know, I'm also Canadian as well. But I'm here to reflect on some aspects that sometimes can be forgotten when we think about the pandemic and we focus on vaccines and the medical aspect. And I want to focus today on some of the social and behavioral and demographic issues. So what we noticed throughout the pandemic is there's certain lessons that we can learn. And I'm just trying to advance my slides. I'm just waiting for it to advance. And I guess I'll just tell you a few of them while we go on. So some of the things we've learned, the first thing is that modeling is key. So what we needed to do during this pandemic is we needed to use different types of data and perspectives. And what we really required was a multidisciplinary approach, just to really look across the spectrum and join the dots. So this came from looking at things such as genomic data, mobile phone data, data about cases and infection and testing and hospitalizations and deaths, and really thinking about public attitudes and bringing all of these things together to really understand behavior and how people were reacting and how we could move forward and solve the crisis that we were in. Another aspect I want to focus on today is about the importance of population composition and also the value of social behavioral approaches to really understand, whether these public health interventions can work, but also just focusing on communications and how vital that was. So I'll start with the importance of demography and just understanding your population and understanding who is where and how they will react and how you can be agile. So we noticed early on, and this is some work I did with Jennifer Beam Dowd shown here as well. And we realized that something that was really important was to understand the population composition and how that interacted with the pandemic. And we do this often in epidemiology and public health. But what we realized, looking at this from a social and demographic perspective, this just shows you, these graphs show they're a classic population pyramid. And it's just showing you the differences in age structure by population. And so we looked and we realized early on in early 2020 that when we looked at the case fatality rates in Italy, it was clearly affecting older age groups. So just based on your age composition of the population, you will have it rolling out in different ways, but you'll also have it resulting in higher mortality in certain countries as well, just due to the fact, for example, that Italy has a very old age structure. And then we thought about it, looking at it internationally as well, too, and thinking about what would happen early in 2020. And this is often what we've done throughout the pandemic, is try to understand international examples. And we worked with Bambagay, shown here, and some other African researchers, and really thought and definitely we're seeing this now in multiple levels, that just because of the population composition and how this virus interacts and affects different groups, and there's different comorbidity structures in different populations, they'll be impacted in a different way. But also, we've learned that different countries, for example, for Ebola or H1N1, different countries had different experiences and different levels of preparedness. Many of the Western countries, particularly in Europe, were not prepared, and for this reason, they didn't act quickly. And for example, in some areas in Africa, they had very strict lockdown measures, and they acted, and also in Asia, as we know as well too. So we really wanted to stand back and reflect. And I think what the social behavioral sciences has also looked at is, yes, it's the age structure. It's also the timing and the type of social isolation measures. But also, very importantly, we look at the household and the workplace as well. So we realized that levels of intergenerational contact and multi-generational households were particularly important in thinking about transmission and levels of transmission. And another thing that demographers are very much interested in, and we worked on it as many, have looked at just how we've turned back the gains that we've had in life expectancy and lifespan inequality over time. What we noticed, particularly in England and Wales, but this occurred in many countries, is just this shows you on the left panel A, life expectancy at birth, and panel B, lifespan inequality. We had made these huge gains in lifespan over the last decades, and those were just turned around in many years due to excess mortality and just the age-related impact of the pandemic. So, life expectancy at birth, went down, and we saw these huge decreases just within a very short period of time that you normally wouldn't see in the population. We noticed that COVID really lowered the life expectancy in most countries. And this we published recently in the European Journal of Epidemiology. This shows life expectancy at birth and life expectancy at age 60. And then we show the differences. Men are shown in blue, women are shown in red. And we show the differences from 2015 to 2020. Normally, you wouldn't see this kind of drastic change over time. But we were already seeing that it wiped out, the last 5 years of gains in life expectancy. So these are really crucial demographic changes, and these affect planning and housing and pensions and deeply impact many other institutions beyond just healthcare. And as was already discussed, COVID resulted in an exposed deep inequalities within many societies. And we also looked at how these inequalities were related to the introduction of non-pharmaceutical interventions, so NPIs. And when I speak about NPIs, I'm sure everyone knows what those are until now. So wearing a face covering, working at home, social distancing or physical distancing, and these kind of aspects. So we realized early on in England and Wales and in the UK that there was a very geographically distinct mortality across the different, once we looked at the different maps across the country. And this was very much related to the mismatch. And this is some of the lessons we can learn with levels of social deprivation, intergenerational households, and the different composition of different populations across different areas. And this, I'm using England and Wales because we studied it, but you can imagine across Canada and other countries as well. There was a mismatch in terms of, the hospital beds that were available and the populations that were in those surrounding regions. And I'll show you what I mean about that in a moment. So we gathered that data together and, created an interactive dashboard where we tried to think about this and tried to think about populations and who would be harder hit and why they would be harder hit. So these inequalities occurred across multiple ways with this pandemic in terms of age, of course, which is often discussed, but also those in areas of higher social deprivation. those living in very dense population areas, and those within intergenerational households. So you could really see already, and this was in March 2020 when we started to make these maps, so we really could see and predict just based on very basic aspects of the population where you think they would have the most problems. And indeed, this shows a map of London, and then on the right you'll see the population, and we'll see that the area of Harrow, for example, has a much older population. So just based on age, you can imagine, and we thought, okay, well, this will be one of the areas. It's got an old population. It's got a very low level of hospital beds. And indeed, actually, they were the first hospital that declared what's called a critical incident, so they could no longer handle the situation. And that was on the 20th of March, 3 days before the government decided to have the first lockdown in the UK. So just based on understanding your population, we've learned that you can say a lot already and do some predictive planning in terms of moving resources quickly. And this just shows London. And what's really important to understand is you have to do fine grain modeling, and you have to look at social deprivation and ethnicity and comorbidities and many different factors. But we believe that this could help us prepare for many areas for the future. So that fine grain mapping using multiple data sources was key. We also looked at aspects such as occupation, and this was the case in many countries. I'm just showing you the mortality rates taken from death certificates by men, by their occupation, ethnicity, and physical proximity of how they worked. So we're talking a lot in many countries about working from home, but remember, in about 60% of the population in most countries cannot work from home. So they're engaged in services, or they have to take public transport to work, or they're engaged in close contact as part of their job. So this shows you age standardized death rates related to COVID by physical proximity of employment. The bubble shows how many people were in that occupation, and the darker it is, the darker, the higher number of ethnic minorities. So this just shows what we call in social sciences intersectionality. So just multiple things, cumulative inequalities resulted in here. So we had higher deaths, for those close contact workers, ambulance staff, care home workers, also transport. But also we had, if you would look at the women's mortality rates, it was also people working in sewing factories. And so this could be related to how you might want to plan ventilation and workspace in the future as well. And we also wanted to really understand this group, because there's often this focus of working from home and doing what you can. Well, what about the 60% of people that can't follow that? And that's related to their living situation, or it's related to their occupation. So we looked at factors that were affecting whether people could even adhere to these non-pharmaceutical interventions. And we used what I think is a really important study in the UK. It's one of the few that's a longitudinal repeated study of people, and it has actual tests of COVID infections. And we used that, and we had about 400,000 tests in 73,000 households of about 100,000 individuals, and we looked at them across the labor market. We wanted to see, were they able to stay at home? Did they have to take public transport? And could they remain distanced, for example? We looked at different periods, and this is something we've also learned about the importance of locking down early or making decisions early. And the UK and England in particular was an example that did not act very early. So you can see this graph just shows 3 periods of lockdowns, various things related to restricting social gatherings or when schools reopen. And we use all of these different policy moments as a sort of a moment in our modeling to try to understand, how was it related to cases and deaths. So deaths is shown in red and cases is shown in blue. And this is certainly continued on. This only goes until March 2021. And I'll show you in a moment later periods. And what was really important to understand here is if you were able to abide by working at home or maintaining physical distancing, you had a much lower level of infections. And I know it makes sense, but it's something that we often forget when we think about the large, population that is unable to follow these things, not because they don't want to, but because they just simply can't, and the conditions aren't made for them in their workplace or in their household to allow them to do that. But what was very interesting from this study is face coverings were one of the MPIs that could actually reduce infection. So if you did have to go on public transport where you couldn't maintain social distancing, if you did wear a face covering, that significantly lowered your chances of being infected, which is really important considering, at least in the UK, the discussion about whether face coverings were effective or not. And also the forgotten aspect of households. So particularly women in larger households were more likely to become infected. And we're thinking now as we phase out to a new stage and thinking, will this be endemic? What's happened and how have people reacted in terms of adhering to different non-pharmaceutical interventions? And this just gives you an idea, looking at one subsection of the population. And remember, we have to look at different types of data. This shows you in the UK from the 1st of April to the 22nd of September. And basically you saw, we can see wearing a mask, that's gone down. Avoiding contact with people has gone down. So a lot, there's been a drop in many adherence to these. And that's largely related to the strategies and the public messaging, where things are often in the UK related to, they're not mandatory, but they're related to your own personal judgment, which has caused quite a bit of confusion. So messaging remains important. This shows people reporting where they're wearing face coverings. It's mostly in public transport and shopping indoors. But I think the relevant figure here is, did you see other people wearing masks? It's light green, it's in the middle. And you can see that that's dropped down to very low levels. So there's some areas where, and also in public transport at the moment, with one of the highest infection rates in Europe, people are not abiding by these, and it has not been brought in as mandatory. So messaging and understanding this and people getting clear guidance has been another thing we've learned from the pandemic. And this just shows you, and I'm sure many of you have been following this, the daily new confirmed cases. You can see in the UK, we had a spike in July where things were all MPIs, where many of them were dropped. And then we had returns to school, and we are having huge increases in Germany, the Netherlands, and Austria at this moment. So of course, there's a whole bunch of things you could talk about in terms of bias in infection data and testing regimes and all of these aspects. But definitely in the UK, we're seeing a lot of confirmed cases at the moment. And I think it's really important, coming back to understanding what are these cases. And this contour plot shows you age by time over the last year from October 2020 to 2021. The darkest shows the lowest number of cases. And if it's a heat map, so red shows you have the highest number of cases. And what you'll see is, this huge January spike in terms of the age groups right after Christmas. And then you'll see in July, early July, the Prime Minister had first announced it on July 19th as Freedom Day, which people really grasped. And you can see that in the infection rates. And many of the MPIs were dropped. And then what you'll see in the bottom right-hand corner of this graph is really high infection rates in children. And the UK, England was one of the countries that made the decision to vaccinate children quite late and only started doing it in the fall. So you'll see the high infection rates in schools, but then the little bubble above that is their parents, of course, and then the peak is their grandparents. So you can see this intergenerational infections as well. So just moving to sort of, why would we take this social behavioral approach? And I want to move beyond looking at the composition of populations and some of the modeling, but what we've also contributed to, and we've spoken about this a lot in some of the UK emergency committees, is just how humans perceive all of this and how we interact with each other. And I'm happy to be speaking at the Royal Society of Canada, and I worked on a committee at the Royal Society, and I think we really made a lot of impact in terms of producing some systematic reviews, looking at different aspects. So in June of last year, we published very systematic coverage over face masks and coverings, because at the time, England was one of the few countries that had not introduced face coverings. This shows Charlie Rahal, who I worked on with this, and we did a very systematic review of everything published on this topic, and you can look at it. It's all available open access. We saw this huge increase in research on face coverings and face masks. And at the time, the chief scientific advisors were saying that it was unclear whether there was any evidence available. This becomes important later when I talk about misinformation. And what we found is it's key for face coverings, but it's also key for vaccine uptake. It's key for many different things. It's just the public understanding, what's happening. So there was a focus on hand washing, but then it soon moved to thinking about aerosols and aerosol transmission. And as soon as the public grasped that, then they wanted to wear face coverings. They understood it. And I think sometimes in communications, at least here, that's been forgotten. And risk perception is very key. We're seeing that there's large groups here in Europe, particularly younger groups that aren't getting vaccinated because they don't feel that they're hospitalization. So that's important. And also the path dependence. I mentioned earlier, previous nations that had experiences with pandemics acted very quickly, and they were quick, clear, and they moved. And as a result, I think they had a different experience. And individual characteristics, I spoke about that before. And you really have to work with the public to imagine what their barriers are. So if it's in relation to face coverings, what do I wear? How do I wear it early on? But also in relation to vaccine uptake. So are you going to have mobile units? How do I get there? Can I take time off work? All of those aspects remain important. And that's what we found and others from previous research. So I wanted to give this example of the Royal Society. So we worked with the Royal Society, and the president, Venki, a Nobel Prize winner in medicine, came out and said, we have this report, and we pushed on the 26th of June. And the mayor of London and many people came on and said, look, there's this report, there's this evidence, we really have to introduce face coverings. And as of then it was announced on July 14th. And we did a lot of media on it. And I think it's really important for scientists to also be public and come out and say, this is something that we have to do, and the evidence is clear now. Because there was a lot of discussion that there wasn't evidence about the effectiveness of non-pharmaceutical interventions. And that's been an issue throughout the pandemic. So to just give you another example, we also developed simulations based on stochastic infection curve models with social network models. We really wanted to think, how effective are social bubbles, and how can we inform, with some empirical data, how you could create the best and most efficient social bubble. And we worked with different multinational companies, schools and universities throughout the world, and where they implemented some of these strategies based on our simulations. So it's just, I won't go into the detail of it, but, it's seeking similarity in terms of, having the same kind of contact partners. You have to work within your community, but you also have to build these social bubbles through repeated contact. So the same shifts, the same students in certain areas. And we've seen these kind of things have worked very effectively throughout the pandemic. So that's something that we now have the evidence. This is simulations because we did it in March 2020, but we now also have real-time data from different companies and different schools where this is born to be the case. So we just showed how you could use social network and understanding the interaction between individuals, how you could flatten the curve in terms of infections. And then another aspect that we worked on as well, too, was about vaccine deployment. And not so much about the operational aspects of it or the efficacy and all of those other aspects, but it was rather if you brought it, would people take it? How would they react to it? And at that moment, we realized that there was so much information, the infodemic, that it was a real problem for people to understand. And that continues in many countries and in many different groups at the moment as well. So we realized we needed to do some strategizing and try to think of some phrases. And this is, of course, standing on the shoulders of others that have worked in this area. But just, thinking if people are hesitant about taking these vaccines, how can you communicate it? So we worked with some researchers in Africa and in the UK and, thought, well, what about the 5 C's? So you have to be, build confidence. You have to deal with complacency that I talked about before. It has to be convenient. You have to know about communications, and I'll talk about that now, in terms of where do people get their information. And you have to really think about their context, their sort of history of dealing with the government and dealing with experts and how much trust there will be within those groups. So I think those are things that we also really learned. And another aspect was just about the huge amount of disinformation in social media, which was hard to avoid when we were doing this. And this has it just repeats itself over time. If you've looked at the smallpox vaccine in the 1800s and the pamphlets that were produced, they're almost replicated with the anti-vax movement now as well. And of course, the MMR vaccine and many of these things. And it was really difficult for people who honestly weren't anti-vaccine, but it was really difficult for them to understand, what's true and what's not. And also, when there were side effects reported, people overestimated the risk of that. And it's really difficult for people to understand, risks. I mean, we buy lottery tickets, so, we really don't understand our risk very well. And it was really interesting. We looked at as well, where do people get their information? And this was where a lot of the disinformation was on YouTube and Instagram, TikTok. And you could really see that was important. And it wasn't just these conservative libertarian groups. It was lots of different groups. But many of them turned it to make it into a discussion about civil liberties and lockdowns. And some of them made quite a bit of money from it, selling natural health remedies as well, too. And of course, there's some studies that have shown clearly that there were some nefarious bots and different groups that were quite organized in spreading the misinformation. And what they do is they exploit changes in advice, changes in science, changes in thinking, which was what was happening during the pandemic. And it's what happens in science. But they exploit that and they state that it's failure. And they play on that. And they say it's political failure and scientific failure. And that is something that they repeat over and over again. And so it's very frustrating as a scientist working in this area. So we started to look at it and we realized it was a lot related to trust and whether people, had these conspiracy beliefs and where they got their information from. This just shows you something we published from the UK, but we've now done it across many different countries in the world. And that will be coming out soon. And we really found that people were less willing to get a vaccine when they distrusted it, when they got their information that was related to conspiracy beliefs, particularly when they mistrust the government. And that, just developed into this misinformation. And it was really quite clear, particularly for those on YouTube that got their information there and not from mainstream media, that they really got fundamentally different types of information. And there's been many analyses of YouTube and other social media, just saying that there's a lot of non-experts acting as experts, giving this information. So I went into a discussion, and this was in the British Medical Journal, should we criminalize this kind of behavior? And we've just seen, actually, there was a few days ago, there was a liable suit that actually went through against the InfoWars person, Alex Jones. So there is some movement in this area. But definitely, I just wanted to highlight what many scientists have experienced throughout this, and I know I'm not the only one. But just in terms of when you ever publish on anything, you get these emails constantly, and this constant barrage of things. I can't even believe I'm covering up their identity. I'm being kind to them, but you get all of these emails, just telling you that you can't look at this. So it's very frustrating. So I think it's been a real turn in science. And just to conclude, I wanted to talk about vaccine passports and the work that we've done in the Royal Society in that area. We published something as well in Science on this and various opinion pieces, where we really thought that vaccine passports could be something interesting, or COVID certification. And I know in Canada, they've been introduced in various provinces in different ways. And, so we thought about things in terms of interoperability, like, technically, how do they have to be introduced? Ethically, what are the different aspects? What about privacy, data privacy? So we had these 12 criteria, and that was a real talking point as well that we created as the Royal Society to really think about these aspects. And I'll just conclude with the last study, and this will be it's forthcoming in Lancet Public Health. We tried to think, well, what are the impacts of these non-pharmaceutical interventions like COVID certificates on vaccine uptake? Because we had heard some accounts, such as in France and Italy, that they had been used to increase vaccine uptake. So we examined 6 countries, and I won't go into all the details because I can see my time is almost up. So I'll just go to the main result. And this will be forthcoming soon. If you just look at the right-hand side of the graph, I think that sort of tells the story. And what we did with this synthetic control modeling is we created a counterfactual. So comparing France to countries where they didn't introduce COVID certification, we saw this huge anticipation effect of people wanting to get vaccinated, and people actually getting vaccinated. About 20 days before. And then we saw about 40 days after that, we saw this sort of durability in people, still getting vaccinated just because of the introduction of these COVID certificates. And they were in museums, restaurants, everywhere. We replicated this across 6 countries. So it was really interesting to think about this, and I know that many countries have now introduced them and thought about it further. Now, of course, France and Italy, France had such a large effect as well. These are countries with a history of vaccine hesitancy and anti-vaccination movements. So I think, as we say in the article, this was where these kind of interventions had the most impact. So I'm just going to conclude now and just move to my last slide, if it's kind of taken its time to get there. But I guess I just wanted to just conclude with just saying to you, what have we learned? So we've learned that, social behavioral aspects are really important. We've learned that communication is important, that public perceptions of risk are important, that understanding how people interact is important. Understanding people's, that they can't follow non-pharmaceutical interventions sometimes because of their own job circumstances or living circumstances. And we've learned that we have to be multidisciplinary and use lots of different data and different data points. So, there, it's finally moving. If you're interested, I'm going to end now and turn it over. If you're interested, we also, with the Royal Society, produced, some public interaction and videos about what would a world that didn't have vaccines, what would that be like as well, too. So I'll end here, and I turn it back to Emily now.
Thank you, Melinda, for really this illuminating presentation. As ever, your capacity to distill such a massive amount of original research spanning a wide range of issues is really just astounding. And from a personal standpoint, it's really inspiring to see how you wielded those demographic insights to support data-driven decision-making. And I suspect maybe this is for a future paper, because you just have plenty of time on your hands, obviously, that morbidity and mortality was really avoided as a result of some of the pieces that you put forward. And of course, it's a team sport, right? It's a collective effort, but really admirable research. So thank you very much for that. And because with this collective endeavor, we know that knowledge really it transcends boundaries at this point. And I think that is something that we will want to keep from COVID-19. And certainly Canada has been looking to the UK. We've heard these some of these decisions were made and were taken up because other countries were doing it. So taking you a little bit on that front then on the data-driven decision making, you're providing very high-level advice to many decision makers and across highly heterogeneous policy and population contexts. And so I would be interested to know, what would you say is the low-hanging fruit that you would recommend to decision makers, and why?
I think one thing I noticed across the different government departments is that we need more coordination. That's certainly the case. So you could often see many different groups asking the same question, or you could often see one group asking the question in quite a narrow way, whereas there was another group asking it in a broader way. So I think we have to learn how to interact in a better way, and I think involve different kinds of experts as well too. I think that's what we've learned. It's been very important.
Mm-hmm. So the coordination of knowledge, coordination across the different learning systems, certainly in the Westminster system, which is also the one we have, the siloed government perspective, I think is something of a challenge. But there are movements afoot to do more integrated policy making. So that would be something that you would highly recommend. So to push you maybe a little bit further, how concretely, how would you say that could happen? What are some of the venues that you've found particularly fruitful for making sure that this knowledge comes across and is that the uptake is wide and broad?
I found that particularly using just thinking about using the big groups such as the Royal Society, or working with the UK government, or working across these sort of larger groups. I found that was quite important because that had some authority, and actually, we looked at trust in science, and others have looked at it as well. Because actually, the public had a high trust, in experts and scientists, and they would actually listen to what they were saying. And there was lower trust in government, not just in the UK, but across different countries. So I think scientists really learned that we had something to say, but that we also had to start to interact with each other as well too. So I think the multidisciplinary aspect, I know we talked about it before, but just looking at, for example, on the UK, the Science and Emergencies group, we really met together, and you had the modeling people there, and often, they would be modeling deaths and things from a very medical side, or they'd be thinking about vaccinations from an individual, but not thinking about the population level immunity. And, and so we really had to join together to try to understand, how could we solve this problem? And then you would come to it, and you can bring the vaccines, but people have to understand that they work, or they'll reject them. So social behavioral and demographic insights turned out to be key.
Terrific. So in the same vein, Mark Lothrop is saying, thank you very much for this very interesting presentation. Could you comment on your experience with UK SAGE? How has that worked for integrating social and demographic insights into the UK response? And what are the lessons for the future?
Yeah, so that question is interesting. So I have to say that it's been a mixed experience in terms of, I'm just being quite honest. Sometimes you were the only social behavioral scientist there, and and things were being discussed, and so you'd have to put up your hand and say, for example, on vaccine uptake. So I have demographic training, and I'm a demographer. And, you had to put up your hand and say, well, actually, we don't know the denominator. Do you realize that we don't, in the UK, have a very good idea of that population? We don't know what the population is. So when you're looking at vaccine uptake in ethnic minorities, you can take 3 different data sets, and they'll all give you a different denominator of the, for the population. And that will really affect how you understand vaccine uptake. So it's just those sort of basic things, that we needed to communicate as well too. And so I think particularly the behavioral aspects, that will be something that we'll take with us as well. So population composition, understanding who they are, where they are, how the disease interacts, and as well thinking about behavior, how people react to it, how they understand it, and how you can communicate it best to them so that you can have people come with you rather than have riots and oppose you.
Oh, that's so absolutely so profound because well, I'm a big fan of the podcast, the behind more or less, and they have had a lot of discussions about the population basis and which data set allows you to measure what. And so I think this is really critically important, bringing those demographic insights to the fore. So we have only a couple of minutes left, and so I thought I would leave you with, an easy question, being ironic here. So if you're looking to the medium and longer term, what would be your blue sky recommendation here for some of the challenges that we have faced, that we have seen with COVID-19?
Well, I think, the big question that everyone's asking is, when is this going to become endemic? So when is this going to be over? I think what a lot of people are asking, and what does endemic mean? And, how are we going to move forward? And when will this happen again? Why didn't we predict it? Why didn't we, deal with this? And I think that preparedness, we've seen from some Asian countries that they were better prepared because of their experiences. So I think, we can prepare some sort of pandemic handbook like some of the other countries had, and we should learn from our lessons. That being said, I'm quite surprised at how we're getting second, third, fourth, fifth waves of infections. We're still not learning from some of those aspects. So I think, scientists have to work together from multidisciplinary perspectives. And when we give advice to the government, and they're saying that they follow the science, it would be important that they do follow the science. But the other side of it is that scientists, we have to realize that when we give this information and we say it's all gray and it's all uncertain, they have to make decisions in a very political environment. So we also have to try to think about moving forward. And I think moving forward will be moving towards predictions and scenarios that are built on multiple data points, multiple ways of thinking, and just seeing, how this will pan out. We don't know really, how this with natural selection and evolution, how this virus will mutate, but we do have a pretty good idea about how people will react to things. So I think it's that combination of those things together that will be increasingly important to understand.
Really key. So Melinda, again, thank you very, very much for setting the stage with these social and behavioral insights that really so glaringly show the way forward, some of the way forwards, as we hopefully move out of the crisis phase of this pandemic and into the endemic phase. I think you've set the stage for the discussions that follow very nicely. And I invite the audience to stay on. There's a break now, but come back. There's more to come. So thank you very much, Melinda, and thank you for the audience for joining us.
Thank you.